Hello everyone, my name is Michael Park. I am a second-year ophthalmology resident at Yale, and I'll be presenting a case today for CSEPT. I have no financial disclosures. Begin with the case. Chief complaint was left eye pain. 36-year-old man presented with left eye pain for 4 days, described the pain as a dull ache behind his eye, associated with some mild light sensitivity and blurred vision. On review systems, he denied any recent trauma, denied it to floaters, flashes, currents, or veils, denied any symptoms in the right eye. He reports he had several similar episodes in the last few years. The episodes always occur in the left eye, last for a few days to weeks, and then self-resolve. He saw an eye provider in the past shortly after an episode and was told he had a normal eye exam. Past ocular history, he had none. Past medical history, he had migraine headaches and was on nortriptyline. No allergies. Social history, family history were non-contributory. On exam, his vision was 20/20 in the right eye and 20/25 in his affected eye. Pupils were 4:2 brisk with no RAPD in the right, 4:2 sluggish with no RAPD on the left. IOP was 18 on the right, 51 on the left. Confrontational visual fields, extraocular motility, and color plates were full in both eyes. On gonioscopy, he was open to grade 3 scleral spur, had some trace pigment with no neovascularization or PAS in both eyes. So at this point, I haven't mentioned the slit lamp exam, but just for the sake of brainstorming differentials, we had a patient who had an elevated IOP to 51 with a completely open angle. So some of the differentials that we would be thinking about, I'd like to categorize them into different systems-based approach. Infectious, I was thinking of things like HSV, VZV, CMV. Inflammatory causes could include sarcoidosis, Behçet's, HLA-B27. Vascular causes can include something like a CC fistula, although this would be rare in the absence of any blood in Schlemm's canal, neovascular glaucoma. Trauma can lead to traumatic trabecular meshwork dysfunction, along with hyphemas or microhyphemas, ghost cell glaucoma, hemolytic glaucoma, and some other causes can include pigment dispersion, lens particle, fake lytic glaucoma, Fuch's heterochromic iridocyclitis, and glaucomatocyclitic crisis. On exam, the patient's right eye was completely unremarkable. The left eye, he had some trace to 1+ injection with some ciliary flush. His cornea was clear, although on close inspection, he did have some inferior fine non-granulomatous KPs. Anterior chamber did have some trace cells without much flare, and his iris had no nodules of note, and his lenses were clear. This is a close-up slit lamp photo of his left eye, which shows these small, fine, grayish white, non-granulomatous KPs concentrated along the inferior cornea. And of note, he did have very slight corneal edema in the left eye. Tachymeter showed his thickness was around 590 in the right and 620 on the left, which could explain his decreased visual acuity from 2020 to 2025. His fundus exam was unremarkable in both eyes. He did have a slightly larger cup to disc in the left eye of about 0.65 compared to the right eye, which was about a 0.55, with no disc hemorrhage in either eye. So in summary, we had a 36-year-old man who presented with recurrent episodes of unilateral eye pain associated with some blurred vision and photophobia. On exam, his IOP was elevated to 51 in the left eye, and he was open on gonioscopy. He had some associated trace corneal edema, trace cell with a few discrete white keratoprecipitates along the inferior cornea. So at this point, based on my exam, my leading differential diagnosis for this patient was an entity called Glaucomatocyclitic crisis. This was first described by Posner and Schlossman in 1948. They described this syndrome based on 9 case reports that all shared similar features. These patients all had recurrent unilateral attacks with some mild discomfort or vision, and on exam they had an elevated IOP that was quite elevated, oftentimes greater than 35, with completely open angles on gonioscopy. These patients also had mild anterior chamber reaction in that affected eye with some fine scattered keratoprecipitates, and these crises lasted anywhere from hours to weeks. Interestingly, in between these attacks, these patients had normal IOPs and were completely asymptomatic. And they also had documented negative provocative testing, which is when we basically dilate the eye and see if there's a change or a rise in the IOP following dilation. Based on these clinical symptoms that these patients all shared, they coined the term Posner-Schlossman syndrome. Epidemiology is that it affects mostly younger to middle-aged patients, ages 20 to 50. Men do have a slightly higher incidence and prevalence of getting the disease. Incidence to prevalence, as you can see, is very low. There are several proposed mechanisms for the underlying pathophysiology. One proposed hypothesis is the vascular endothelial dysfunction. Basically, the hypothesis is that there is a local ischemia of iris and trabecular meshwork, which leads to poor trabecular meshwork function and outflow, which can then lead to elevated IOP. This was based on a study by Raita and others. They did an FA of the iris during an acute episode of one of these patients who had clinical diagnosis of Posner-Schlossman syndrome. And they found that there was some sectoral filling defect along the iris in these patients. The next hypothesis is that it's an inflammatory process. They found that there were elevated levels of prostaglandin in the anterior chamber samples in patients who were clinically diagnosed with Posner-Schlossman syndrome. The theory is that elevated prostaglandin can lead to a breakdown of the blood aqueous barrier and lead to an increased production of aqueous fluid, but also the inflammation can lead to cellular debris that clogs up the trabecular meshwork, which leads to decreased outflow and elevated IOP. This was a histopathological slide of a patient who had undergone trabeculectomy. And this is a slide of the trabecular meshwork. You can see here all these cells labeled M are actually mononuclear cells, which suggests that these cells do actually clog up the trabecular meshwork in these patients. Another hypothesis is that there is an underlying infectious etiology. So in this hypothesis, some kind of infectious agents, whether it's H. pylori, HSV, VZV, or CMV, lead to a dysfunction of the trabecular meshwork, as well as white blood cell plugging of the damaged TM, which then leads to decreased aqueous outflow and the elevated IOP that we see in these patients. Of these, CMV actually has the greatest evidence. And in this one paper by Chi and others, they did a retrospective case series of 67 eyes with a clinical diagnosis of Posner-Schlossman syndrome. They looked at baseline characteristics of these patients, along with the presence or absence of CMV on their AC tap. They found that in patients who were diagnosed with Posner-Schlossman syndrome, there was a 52.2% likelihood of them having a CMV PCR positive sample on their AC tap. This was actually in contrast to Fuch's heterochromic iridocyclitis, which is a different clinical entity, which also tended to have quite a high rate of CMV positive eyes on PCR. How do we make this diagnosis? Well, it's a diagnosis of exclusion, and after ruling out any other potential causes of the elevated IOP, including but not limited to things like angle closure glaucoma and infectious or herpetic uveitis, we make this diagnosis really based on their clinical exam. So these patients will present with acute recurrent episodes of unilateral blurred vision, pain, and redness. And these episodes will last anywhere from days to weeks. But they'll usually self-resolve. And on exam, they'll oftentimes have some trace AC cell and possibly some fine scattered KPs. But the hallmark is that their IOP elevation, which usually occurs in the 40s or 50s, in the absence of any closed angles, occurs out of proportion to the degree of AC inflammation. Their visual acuity can be very good or very poor depending on the degree of corneal edema, and they can develop glaucomatous optic nerve damage from repeated episodes. Additional lab studies such as AC tap, looking for HSV, VZV, CMV, is not necessary for the diagnosis, but it may be important to rule out other potential causes of the patient's acute episode. Some of these, this is a picture that was published that describes and illustrates these fine KPs that these patients often develop. You can see that they are pretty small and concentrated along the inferior cornea. They're non-granulomatous, and they have this whitish gray appearance to them. You can see that our patient had a very similar distribution and appearance of the keratoprecipitates. Management of these patients includes IOP control. You can treat them with topical antihypertensives, oral carbonic anhydrase inhibitors, or an AC tap for both diagnostic and therapeutic purposes. There's a study that suggests that we should avoid prostaglandins, which makes sense, given that there may be an underlying inflammatory or infectious etiology that triggers these episodes. We also want to control their inflammation with topical prednisolone, oral NSAIDs, and cycloplegics. Treatment of underlying CMV, if the AC tap returns positive for CMV, has also been shown to improve outcome in these patients, and that would be treatment with topical ganciclovir, the 2% gel. Eventually, if these patients develop severe glaucoma in the affected eye from recurrent episodes, there are surgeries that are that can be used, the traditional trabeculectomy or tubes. Prognosis of these patients, a lot of them actually do develop quite severe glaucomatous damage over the course of a long period of time. So in one study, looking at 53 eyes of 50 patients, 14 eyes, just over a quarter of them, developed glaucomatous damage in 10 years. They also found in the study that patients who were diagnosed for 10 or more years with this disease had a 2.8 times higher risk of developing glaucoma compared to patients who had been diagnosed for less than 10 years. The same study found that 9 eyes, or 17% of their sample, underwent trabeculectomy with mitomycin C or 5-FU, which is quite surprising. I thought that these episodes usually lasted no more than a few days to weeks, but with recurrent episodes, it just goes to show that these patients can develop really bad glaucoma in that affected eye. One other entity that I wanted to mention was Fuchs heterochromic iridocyclitis, which for me has always been a confusing topic and difficult to distinguish between or from Posner-Schlossman syndrome. So unlike Posner-Schlossman syndrome, which is characterized by these recurrent acute episodes of really elevated IOP, Fuchs is really characterized by chronic, low-grade, unilateral inflammation that can be associated with borderline elevated IOPs. Like Posner-Schlossman, the underlying etiology has been linked to CMV and rubella, as some of these patients with this clinical diagnosis had positive AC taps for rubella PCR as well as CMV. Presentation is very different from Posner-Schlossman syndrome. So patients with Fuchs are typically asymptomatic, and they have this chronic low-grade inflammation with some very minimal elevation in their IOP that can go undiagnosed for a long time because they're asymptomatic. Whereas Posner-Schlossman syndrome, as you saw for this case, they present with an acute unilateral eye pain and acute elevations in IOP elevation. Fuchs is also associated with several exam findings that are unique, including heterochromia, and they have this characteristic fine vessels that grow over the iris and cross the trabecular meshwork, which can lead to bleeding, especially during cataract surgery, which is known as Amsler's sign. So just to kind of wrap up with our case, when I initially saw the patient, their IOP was elevated to 51 and they had some trace anterior chamber cell. Performed an AC tap, their IOP came down to 6. We sent the AC tap for HSV, VZV, and CMV PCRs, which all returned negative. The patient was started on topical prednisolone acetate, as well as some IOP lowering drops. The following day, the patient returned to clinic. They reported that their symptoms had completely resolved. Their IOP was 13, and they had trace cell, but it was a little bit better than the day before, and we recommended a weekly prednisolone acetate taper. Patient was supposed to follow up actually 1 week later, but they were lost to follow up. I'd like to thank Dr. Combo for help managing this patient and for putting these slides together. I'd like to end with a few questions that I'll leave up here. So the first question, true or false, patients with Pocher-Schlossman syndrome often have extreme cell flare on exam out of proportion to their degree of IOP elevation. 2, which of the following are appropriate treatments for Pocher-Schlossman syndrome? A, timolol, B, prednisolone acetate, C, topical ganciclovir, D, cyclopentolate, or E, all of the above. And 3, which infection has Pocher-Schlossman syndrome been most commonly associated with? Thank you for your time.